Thank you so much, Lloyd. As Lloyd said, there will be an afternoon session in which we don't have a built-in question and answer period right now, but you'll be able to ask questions and engage in a lot more dialogue about collaborative care, both present and the future, from folks who are living it and doing it. So it should be a great breakout session. Why don't I have our panel members come up to the podium for the next session, for the leadership panel. And while they're doing that, I'll briefly introduce them and just frame the goals for the next hour that we have. We invited and are extremely pleased to have a group of physician leaders who all are knights. They were pre-screened. And they all play a prominent role in graduate medical education within their institutions, in their communities, in New York, across the state, as members of their respective professional organizations, and in many cases play a national role as well on some of the issues that we're going to be talking about. So I want to welcome Drs. Clarke, Kalman, Tung, Campbell, and Swartz, who collectively represent the perspectives of the triumvirate of primary care disciplines, at least the triumvirate that are part of this demonstration, and that includes pediatrics, family medicine, and internal medicine. And as you'll see, they practice across different settings and work across New York geography. I've asked them to briefly begin by introducing themselves. You can read the more extended version of their accomplishments, but you're just going to have to trust me that if they weren't very smart or accomplished and important, they would not be on this panel. And we've given them a very short period of time to make a few points regarding some of the challenges and opportunities of medical home advanced primary care from their point of view. And we'll invite questions and comments both among the panel and also between you all and the panel after they finish. In particular, we asked them to tee up for their thoughts and observations what the implications are of the future job description for primary care for graduate medical education programs, many of the issues that you heard Dr. Jane tee up as well. What's different? What needs to change? What are some of the challenges ahead? How do we make primary care reform work for training programs, for trainees, and for our patients? So please join me in welcoming our panel, and I'd like to have Dr. David Clarke begin with his comments. So.
Thank you. It's a pleasure to be here. Too many comments turns knights into knaves, so we have to be careful in terms of those sorts of things too. What I'm going to do today is somewhat slightly provocative. I will probably irritate at least 2 or 3 people in the group, and that's somewhat intentional. All of you have a pet project of some sort, and I may touch on some of those somewhere along the way too. By disclosure, first of all, I'm Albany Medical Center, but I'm a native of Binghamton, New York, practiced for 11 years in Syracuse and 4 years in Westchester County. Gained weight for 10 years in New Orleans, then came back to Albany, been there for 16 years. So I know upstate New York pretty well, and Westchester gets a pretty decent view of what's occurring in New York City, which, as you know, is more than a little complex. Second thing, Albany Medical Center, we serve a much larger area than folks realize. Most of you recognize Albany as where the Medicaid money comes from and all your regulations, some of your water from the Hudson River, and a few other things, a few produce and other sorts of things. So we're still relatively important. We're currently the 4th largest population base, the capital region, not small Albany. As I know, it's a proper term in New York City, but it's actually 5 cities and 4 counties, and there are more people in suburbs in between those 5 cities than there are in the 5 cities put together. But it's a large population base. By 2016, we will exceed Buffalo, be 3rd after New York City, Yonkers, then the capital region. Buffalo being 4th, we're growing slightly. Buffalo is shrinking slightly. As you all know, in 2015, Florida is going to catch New York. And so we'll be not one of the 3 largest, one of the 4 largest states in the country with about 1/3 of the kids, which is why what happens in New York State is very important for the national agenda of national health insurance. We cover an area of about 40% of the state of New York. Well, without getting evangelistic, we cover about 23 counties, 2 more counties, southern Vermont, western Massachusetts will come our direction, about 610,000 kids and about 3 times as many adults in that population base. We have the only pediatric intensive care unit, the only high level. All the specialists for that region are residing in Albany, and we have very warm relationships with Syracuse and Westchester County, the 2 closest medical schools. That's enough disclosure. Where are we going? Well, this is the Academy of Pediatrics definition. It varies a little bit from what's commonly seen as the medical home. But the components, if you can't read what's on the left side, are accessible, family-centered, continuous care. Family-centered is more a pediatric issue than it is adults. It tends to be more patient-centered than family-centered in adults. Continuous, comprehensive, coordinated, compassionate, and culturally effective, all important issues. We have some issues, though. We have some things that are providing care for not only children but adults that are really not medical homes. An emergency department, though housed in hospitals, is a vehicle for admitting patients to hospitals, but well over 80% of children, at least in upstate New York, and over 60% of adults appearing in emergency rooms don't have an emergency. Why? Because they don't have a medical home that provides care in off hours, which provides an opening, obviously, for urgent care, minute clinics, and other sorts of things, too. The first provocative things you may see here, too, is I've included school-based clinics, and there's a specific reason for that, and we'll come to that in just a second. Also did mention alternative medicine. Though adults get to choose, children aren't necessarily appropriate for some of the alternative medicine provided out there. Without hopefully not offending anyone in the crowd, chiropractic care for children is very debatable, and certainly their stand against immunizations is incredibly important for pediatrics, since clean water immunizations are the two most important things that have ever been done for the health of children overall. And these are the reasons that those are not medical homes, though they're accessible, especially minute clinics in Walmart and other sorts of places. Family-centered, continuous, comprehensive, coordinated, not so much. Tend not to be family-centered, more patient-centered, get through this specific episode. Continuous, rarely, especially individuals without insurance that may use multiple emergency departments or multiple minute clinics. Therefore, the exchange of information, what really was done, what medications were done, is not always there. Comprehensive, rarely. It's almost all episode-based care. Coordinated, almost never. The electronic medical records don't communicate effectively with each other. Compassionate, I'm not going to argue that particular point, and may well be culturally effective. If not so, they might be serving that community. Well, specific to pediatric residency training, your medical school and training afterwards is how you get your license. Your board certification is how you get paid to practice what you're doing. Paneling and certainly CMS in the not too distant future may require board certification and maintenance of certification as the key issues for continuing to get paid as we move chaotically towards national health insurance, and maybe women and children first, but it's still going to be a big issue for that too. Issue with pediatrics, there's two groups that are very important for all residency training programs. There's the Association Accreditation Council for Graduate Medical Education. This determines the program requirements. It's a many-page document in general, close to 100 pages in general, but for pediatrics, it's another 70 pages just for pediatrics, what has to be there. As part of that, there's specific minimum rotations. Typically now, a program can have no less than 2 months in the neonatal intensive care, 2 months in the peds intensive care, but no more than 5 months intensive care total. So we're getting to the point right now that the amount of critical care training is less than it used to be. Is that a bad thing or a good thing? Well, many folks are going into a smaller community and are required to go to deliveries and do the resuscitation. They're viewing that as a bit of a problem and are looking to have a little more experience. The NRP course by itself is learning, but not necessarily competency with that too. Several of newborn, incredibly important wherever they're going to be going to. But 10 hospital units, and we talk units now, it used to be months. It used to be 36 months with 33 required months certified to the Board of Pediatrics. It's now units. Units are 4 weeks, so now there are 13 units per year. So you have to have 36 of those units, 3 units off for vacation. So it's 36 units that are required. And with that, who requires it was not just the ACGME, the Residency Review Committee, but it's also the American Board of Pediatrics. To be able to take the board, you have to meet the requirements. The American Board now has a collaboration called the Milestones Project, which is in detail documentation of the individual capability of that particular resident, including all the things that you've seen for medical students along the way in terms of cultural sensitivity, compassionate, technical, all those sorts of things too. Transitions. Pediatric has 2 major transitions, one from birth to life, or prenatal, if you believe it. A fetus certainly 24 weeks and above, as a neonatologist, is certainly in the ballpark of salvageability, but a great range from 24 to 42 weeks of what may be done. First major transition, and probably the most dangerous transition in your life. Not everyone does that smoothly. Not everyone has the ability to survive even with high technology. Second major transition is somewhere near late adolescence. It may be 15, 16, depending where you are, and maybe 21. Pediatrics, American Academy now suggesting through college, which is 21 or so. Some keep to 25. And the child has a complex and unusual disease. Read that PKU, or post-op congenital heart disease with several things, they may be kept much longer than that, especially by the pediatric subspecialist. So somewhere in that ballpark. If you're cared for by a family practice physician, that may be continuous without a transition. However, most adolescents move somewhere along the way, so it's to a new physician, even if it's another family physician. Transitions for adults, of course, are on the front end, taking the late adolescent. Back end, just the reverse, it's life to death. Pediatric primary care, the major thing that pediatrics does, and we need to teach, of course, is preventive care. Immunizations is the prototype, but beyond that too, newborn screening, metabolic screening has become ever more complex and difficult. We're moving from that to something much more complex than that too. Hearing and vision, why are those an issue? Because we need to prepare these children for school. Vision, hearing are the two major things in terms of impediments for learning. Oral health, the most common and severe epidemic in the country is caries, variable depending where there is and is not fluoride too. But the cost of providing children with fluoride and appropriate care compared to the cost of caries and tooth extractions is massive. Growth and development, not an issue so much for the adults, but very important. The brain is growing through the first 2 years of life and still developing in that phrase well before the teachers ever see them too, but growth and development continued is very important. Many things may interfere with that. Then of course now behavioral. We do not have enough child psychologists or psychiatrists. You all know more than you want to know about ADHD and the other sorts of things. That's several hours worth of topic just by itself. But where are we going? The challenges for training now are training in genetics. We can know at birth what you're at risk for the rest of your life. Epigenetics superimposed upon genetics. Your genome doesn't change, but how it works does change. Expanded newborn screening as part of that, and then drug metabolism. And you all recognize Down syndrome, trisomy 21. 21 actually is the smallest of the autosomes. The number 22 chromosome is physically smaller, but there's less genetic material on the number 21 chromosome. Trisomy 21, you've all seen as one of the more common things, Down syndrome. The issue, it's been discovered just recently in the last couple of years or so, is that in Down syndrome, there are 311 genes that are up or down regulated. Only 5 of those happen to be on the number 21 chromosome. Every other chromosome but the Y chromosome is affected by the presence of a third normal chromosome. We tend not to think that's a normal chromosome. You just have 2 of that one chromosome and 1 from the other parent. So it's a major issue, how it's working. You can see all the things we know just on this one particular chromosome. There's similar patterns for everything else too. Smith's Recognizable Pattern of Human Malformation, sort of a standard book that many of you have seen along the way too, has about 350 syndromes in it as of about 6 months ago. Every syndrome in that book has a specific genetic locus that's been discovered. Well, this is even more complex. This is now the genomic, as we understand it, of AML. AML used to be a disease descriptive. Now we know there are various forms of AML. Some of those can be fairly easily treated, fairly expensively, by turning off a specific enzyme, a tyrosine kinase that should not be expressed. But there are many others. We would know at birth whether or not you have these in your genome, whether or not you're at risk for AML and the type of AML, and whether it's going to be responsive, something that may occur when you're 25, 30, 40 years old. Even more exciting is asthma. We tend to think of asthma having a genetic component, seen more commonly in families where they've had a premature baby. The premature baby is more likely to develop chronic lung disease, and families with asthma too. We start within the genotype, and there are a series of things, this is the environmental health portion now, that modify how that genome is expressed, including antenatal effects. Gotcha. I'll be done by that notion for sure. You just gave me a 2-minute warning, which isn't bad because I have less than 2 minutes. Where are we going? Newborn screening. Right now, it's metabolic screening. The genome, LabCorp claims by the 2015, you'll be able to get an entire genome for less than $1,000. We can save in newborn New York State alone. We can reduce the cost of newborn screening going to genetic screening. We can reduce the cost by 75% compared to our current costs. Now we're doing metabolic testing to get back to genetic disease. Not hearing, obviously, not HIV. But we could do genetic testing and test for many more things that are currently being tested for in New York State. There are implications for that by knowing what's in the human genome. You know the BRCA genes. You know what little girl is going to be at risk for developing breast cancer before she's 30 years old. You know who might have early Alzheimer's. All those sorts of things could be disclosed, could be available. Second part, you notice all the way back to 1998, Francis Collins, a name you probably recognize, in a different role at the time, an American Academy Family Practice meeting, talking about genomics and understanding of how you individually metabolize drugs. So we would know at birth or shortly after whether or not they're classes of drugs you should never get because you cannot metabolize them quickly enough. And as a result, you will always have a toxic result, an adverse reaction, one of the major issues. Others you may metabolize more quickly because you have several potential pathways genetically determined to clear that medication. And as a result, in that configuration, you clear too quickly, you never get a therapeutic level. So the drugs could be tapered to your individual genome. Well, back to what we're doing at Albany Medical Center. What's the impact here? We hope really reporting or representing several departments. Departments of Pediatrics and Medicine were the leads of these two groups too, and divisions in multiple divisions, primary care and HIV division too. 32 peds residents, 16 med peds residents, 48 traditional medicine residents, another 35, total of 83 transitional residents in the program too. Those were the ones that were primarily affected, well over 100, but indirectly affected were the training site for 3 different family practice programs out of Kingston, out of Ellis Hospital in Schenectady, and Albany Medical Center. All programs come to Albany Med for the pediatric training portion, and then 36 emergency medicine. Not the primary focus, but you can't do a project like this and accomplish it without involving the residents coming through the training in those particular programs too. What do we do with the money? Well, we spend it, of course, never turn down money. We're a little over 13 months into the project right now, and without giving a detailed, comprehensive report, which is available, by the way. Primary care focus, multiple divisions involved, a minimum of 5 metrics. Many more were done, but 5 metrics per group, with some overlap from one to the other two. Nurses, social workers, and faculty were all involved too. The support meant mostly for the non-faculty individuals to make sure that the metrics are being covered. You may think you're doing a good job, but you have to prove it to yourself that that's what's being done. And the team process, monitoring that progress is very important too. And then the ambulatory and inpatient blocks for the residency training programs, internal medicine, pediatrics, have been modified to reflect various things that we found for this to improve quality of care. So where was the impact? Getting back to where we should have an impact. Accessible was not an issue. We've had a multi-year project for accessibility to all the primary care and subspecialty groups too. Family-centered, less of an issue before, now very much so. You tend to think of Albany as being sort of a not very diverse area. Nothing could be farther from the truth. We have American Indians, we have a large Amish population, we have immigrant groups from all over the place, displaced people, et cetera. So it's a very diverse population, multiple languages. Continuous care, we were doing pretty good shape with that too. Comprehensive is another major impact to make sure that all the details for any individual were being covered too. Coordination of care, especially primary care physicians to the subspecialists and back, was a major focus. All the department subspecialists involved too. Compassionate care were there, and even culturally effective. We've been able to monitor that much more effectively. And that is just about my time. Thank you very much.
Thank you, Dr. Clarke. Neil?
Thanks. My name is Neil Kalman, and I'm a family physician, and I run an organization called the Institute for Family Health for the last 30 years. And Foster said we have to tell you what that is. So I wrote it down because I can never remember. So we run 29 federally qualified health center sites and have about 1,000 employees with a budget of about $100 million a year. And we do almost exclusively primary care, mental health, and dental services, very, very, very little in the way of specialty care. All of our centers are PCMH level 3. We were recertified in 2011. We just went through the Joint Commission primary care medical home certification. That was a treat. We also run 3 family medicine. I like that one. 3 family medicine residency training programs, 1 rural program up in Kingston and in Ellenville, New York, and 2 in the city. One where we rotate our residents through Beth Israel for their inpatient training, and one where we rotate our residents through Mount Sinai for their inpatient training. And half of those 96 residents are funded through the ACA's Teaching Health Center funding mechanism, so the funding comes directly to community health centers. So if you're interested in that, you can talk to me at lunch. We do about 480,000 visits a year. 20% of those roughly are mental health. All of our centers have integrated mental health services that are available at all times for patients. So we live Lloyd's model embodied in Verna Little, who's our Director of Mental Health Services. And we've been completely electronic on our electronic health record system since 2002. And interestingly, for this discussion, about a third of all of our patients now are in shared savings models that we've negotiated with payers. And for those of you who are payers in the room and who've done that with us, thank you very much, because this really is the future. There are still many people out there who are shying away from these discussions with primary care providers, but we've had them, and we have a number of partners. And we're really excited about working collaboratively with the payers in trying to sort of improve care. So my comments are sort of in two groups. First of all, we're all working on the holy grail triple aim, and I want to say just a couple of words about each of those components. So the biggest issue, I think, in this demonstration project is we're trying to train residents in a PCMH model that's really still in its extremely formative stages. I mean, I consider that we are like in first grade in relationship to where we need to be to transform the healthcare delivery system. And I'll also say that getting from here to where we need to be is what keeps me from retiring, because it is the most exciting thing that's happened in my time in primary care, is really trying to envision, how do we do this? How do we actually, for the first time, be able to look at populations of people? And when I say populations, I mean the people that live in our communities, not just the people who come in for care. How can we actually look at data on populations and see change and feel like we are a part of that change? And that requires work both inside our centers and outside our centers in the community, things that we're increasingly engaged in, and I think things that we need to increasingly engage our residents in. So for people that think that shared savings is not being at risk, you're wrong, because the transformational costs of what we're doing are just extraordinary. We have people we've never hired before, educators, outreach people, a whole cadre of mental health people. We have IT costs that are astronomical, not just the computers, but the reporting out of our technology systems and all of the things we do with the information that comes out. And then we have the cost of all this non-visit based care, for which we still don't really get paid except through these shared savings plans, all the telephone encounters, the electronic messaging with our patients. 20% of our patients are active users of their patient portal and message our providers all the time. Some of our providers get 10 to 12 messages a day from their patients. We've also built a centralized call center so that we can handle calls after hours. And all of the things that need to be done sort of around the reducing healthcare cost stuff is all investments that we're making in models that really haven't been proven yet to reduce healthcare costs. So we're hoping, but it's an evolutionary process. On the sort of, improving care model, I think we are tracking and have tracked since 2003 in a model that we developed with New York City Department of Health, care over 45 different parameters. And I will tell you, and Foster's heard me say this before, if you're not doing something around those, just reporting on them, they just flatline. I mean, there's some parameters that haven't budged in the 10 years that we've been reporting on them because we've never done initiatives in those areas. So we know two things. One is we can improve care in anything we focus on if we put enough energy and resources into it. The second thing is to sustain that requires sustained energy and resources. And the third is that the challenge is doing that across the entire spectrum of things that we have to do in primary care. So the third part of the triple aim, improving health population-based, I think that we just have to, here's one of the things that we've been talking about with our residents, and that is really changing the terminology. I mean, we don't call population-based medicine what you do with a registry, because that's really, you know, the population is the population of people that live around your facilities. And I think if we got our hospitals to think that way, and if we got our centers to think that way, we would be doing a lot more engagement in the community, which would also help us with engaging our own patients. I don't think this is something that we can do inside our walls. So I want to focus just on 4 things that I think are the biggest, well, I won't say the biggest challenges, but major challenges that we face as we sort of go down this path. And I took up golf not that long ago, and I was down in North Carolina, and I was playing with this instructor, and this guy was like doing everything he could but laugh. And I hit the ball in the woods about my 3rd shot, and I said, well, I won't say what I said, but he said, "Great." And I said, "What do you mean great?" He says, "You know, every time I hit a bad shot in the woods or in the deep grass or something, I think it's great. Unless I'm in a tournament." He says, "I think it's great. Where the hell else are you going to get a chance to sort of practice hitting out of the woods or hitting out of the grass? So if you never hit in the grass, you never get to practice it." So I got a lot of practice hitting out of the woods and hitting out of the grass. But I try to remember that in relationship to the toughest problems that we faced. That's the fun part. Any idiot can do the easy stuff. It's the fun part is really what the major challenges are. So here are just 4 that I put down as sort of major challenges. So the first is sort of hanging on to the generalist model while we're sort of doing this stuff. Because as I said before, every time you try to improve care in something, you put a special emphasis. So we have a team of diabetes people and a team of asthma people and a team of people who do substance abuse stuff and different people doing different things. And I keep thinking, so what are we doing? We're sort of recreating a specialty model within our primary care centers where, you know, depending upon what you have, you sort of go into different channels. And I think it's a real challenge to sort of figure out how we do this care improvement through general processes that allow us to improve care and sustain that improvement across a broad sort of generalist kind of view of what it is that we do. Because after all, we take care of people with undifferentiated illness. They don't come in with diabetes. They come in saying they feel sick. And we have to basically figure out how to sustain that on a generalist model. And that is huge. So I don't worry about my residents going off and, you know, doing fellowships in GI or cardiology or whatever. What I worry about is my residents in their 3 years going off and becoming diabetes people or people who are, you know, want to just do geriatrics or they don't want to see kids anymore or they don't want to do this, because that's the way this sort of improvement model is sort of developing, and I think it's helping people to sort of become like little specialists within primary care. So that's something that we pay attention to. The second thing is that people keep touting evidence-based medicine as kind of some big holy grail. And I would just say that it's something that we really need to take with a grain of salt. I mean, evidence is changing all the time. And the commissioner, I'm glad he left, referenced JNC 7 guidelines. Well, there's now JNC 8. And JNC 8 says you've been over-treating hypertension for a long time. And not only that, folks, we've been using the wrong drugs on a lot of people. So, and we just found that out. But also in the last couple of years, we found out that we shouldn't be testing people for PSAs, that we used to track to see what percentage of our people had PSAs, and now we track to make sure nobody's getting routine PSAs. We used to teach, I remember teaching, my preceptors told me that if I did a breast examination on a woman and didn't teach them breast self-examination, we were doing something terrible. And now we know that it's a relatively useless procedure and that we no longer have our people teach it. Mammography has been reduced, you know, in terms of frequency. Pap testing, way reduced in terms of frequency. Physical exams are something that it's a bad word now. We never do them anymore. Calcium and vitamin D, which we used to give all of our postmenopausal women is now restricted to people at only high risk because it actually increases their risk by giving it to them. And we used to always monitor. One of the other things we monitored was make sure we checked people's liver function tests when they were on statins, and that's proven to be totally useless. So all of this stuff has changed in the last 2 years. So what do we teach our residents in the face of all of this? What we teach them is how to maintain a sense of perspective on what we call truth. And truth is today's truth. It's not necessarily, there's nothing permanent about that information. And what do we teach them about how this relates to their relationship with their patients in a patient-centered medical home? It's called shared decision making. We have to be honest. We have to stop telling people what to do. We have to start engaging them in discussions. We have to realize that for everything that we do, there's a counterposing view. And not only that, tomorrow it may be proven to be the actual view. And we have to listen to people. You know, there are people say, I don't want to take those statins. They might hurt me. Well, a couple years later, the ones that we were trying to push on them find out that they did hurt them. And so I think that the view of engaging patients in that conversation is critical. The third challenge is how we teach our residents to relate to the hospital. So when they're residents, most of them are employed by a hospital. But when they graduate, most of them won't be employed by a hospital. And that relationship between the provider and the hospital is something that is yet to be resolved, I think, in terms of what the new model is. So our doctors go in and take care of their own patients in the hospital. We are bucking the hospitalist trend. So we run family medicine services in the hospitals that we're affiliated with. So we think that's a better model because we think patients deserve to have somebody from their primary care team take care of them when they're at their sickest and most vulnerable. But in terms of thinking through what this means around shared care and shared decision making and who on the team really should go to the hospital, who needs to go to the hospital, what our role is there, and what the role of primary care people is in the hospital is really critical. The last thing, the fourth point I want to make is, and many of you have heard me talk about this before, I think we have a problem with our rhetoric around cultural competency and around sort of around this universal access stuff. So the patient-centered medical home is supposed to provide open access, but it's supposed to provide open access to the same type of care for all patients. And many of our residents are training in institutions that have multiple tiers of care, multiple classes of care, and I worry about what that teaches people. What it teaches them is that we say that we believe that everybody is equal, that everybody should have access to the same thing, but we train them in institutions that don't abide by that and that have multiple classes of care for different types of patients, for people that are privately insured. They have separate sections for people who are mentally ill, and I think that kind of segregation of care is really damaging to creating the knights of the future, because basically what we do is we train them in institutions that don't really carry out care the way we would like to do it. So in conclusion, we're teaching residents about the primary care medical home while we're building it. We're doing it in a very difficult environment of a complex academic medical center that has some people in managed care programs and some people in shared savings programs and some people in fee-for-service programs. It's not easy work, but I think it's essential that we continue to innovate and evaluate the results of each of these efforts and focus on the hardest things, those hardest challenges, because that's where the fun is. Thanks.
Hi, my name is Judy Tung. I am the interim chief in the Division of General Internal Medicine at Weill Cornell Medical College, New York Presbyterian Hospital. I've also been the program director for the Primary Care Internal Medicine Primary Care Residency Training Program for about a decade, and will be speaking mostly from that perspective today. It's a real honor to be here among such distinguished thought leaders, and I really thank you for the opportunity to allow me to share a few of my thoughts about payment reform, the future of primary care, and its impact on training programs. So I think the biggest paradigm shift for us will be, of course, the turn of attention away from volume, that get them in, get them out hamster wheel that we all run on, over to quality. And I think that this alignment of our compensation structure with our clinical work is, of course, to be applauded. But it does have a few implications on the way that we teach our residents about what quality is, and I'd like to take 2 minutes to think that through with you. So what quality is, how we define it, how we measure it, how we report it, and how we are asking for our trainees to respond to it is a really, really tall order. And I think that the use of quality metrics is certainly a seductive way of quantifying what quality is, but risks oversimplifying clinical goals for our very busy and our very impressionable trainees. And we all know, for example, that there's so much more that goes into high quality care for a diabetic patient than a hemoglobin A1C, and as I think Neil just accurately categorized, even those well-established targets are always changing under our feet. And so how do we understand and utilize those targets in the future, I think still falls squarely back in the hands of our evidence-based educators. And I don't think that I'm saying anything differently, but I do think that electronic decision supports at their best are a way for us to keep track of a multitude of recommendations, but at their worst become checklists that our trainees blindly follow and don't understand how to either adjust or apply to the individual patient. And the skill set of learning how to take practice-based guidelines and apply them in a nuanced fashion over to individual patients is exactly what EBM teaches us. So as quality becomes a yardstick by which we measure the value of our work, training programs need to ensure that our physicians understand not only the evidence, but again, the application. So how is this different than what we've been doing all along in our EBM curriculum? I believe there are a few. The first actually is in the competing priorities to our curriculum. And as we add important aspects such as patient safety, such as communication skills into our curriculum, we really risk squeezing out some of the core medical knowledge seminars that currently exists. And we have to ensure that our foundation in our scientific skills is not sacrificed. The second is that I think that in our EBM, we really have to spend greater emphasis on the application part of the examination of the medical literature. And what I mean by that is the use of case-based, team-based, self-directed learning formats, which I know many residency programs around the country have innovated with. Ours is called Academic Time, and it is has replaced our sort of noon core seminar series, is led by a facilitator, not a lecturer, and is entirely roundtable, team-based with iPads, finding clinical answers to clinical questions that are, of course, driven around a core medical knowledge topic. And lastly, and I think most importantly, is the incorporation of the residents' personal practice data into these core seminars. So it's great to learn about, who I should be screening for hepatitis C and why, and even how to perhaps individualize it to the case that we've just talked about. But what am I doing actually in my own personal practice, and what should I change about it in the future? And having the residents' performance metrics during each and every one of those seminars woven in, I think is going to be the way that residents will not only understand, but engage and not, and then also, I think, become the next, or spearhead the next phase of quality, which I think is, as Neil indicated, broadening the definition to include perhaps incremental triumphs, and then, of course, the patient's personal goals. I'm going to shift gears a little bit to talk about team-based care, which is, I think, the other paradigm shift that has to occur both for practicing physicians and for trainees. And I think that reform has allowed all of us to acknowledge the contributions of the other members of our team, allowed us to practice up to our license, allowed us to recognize that outcomes really hinges upon the different skills that everyone has to bring to the table. And this ability to work with other individuals, to collaborate, to delegate, to resolve conflicts, to negotiate, is something that I think we have traditionally reserved for only a small subset of our trainees, perhaps our chief residents or other people who step up into leadership roles. And this is going to be a part of every single practicing physician's daily life, how to not only help our residents acquire those skills, but build it actually into their practices, which of course is very limited by the duration of their rotational length, is going to be, I think, a real opportunity for us in the future. Finally, team-based care requires the ability for physicians to share patients. And that's a skill that competes slightly with the cultivation of a strong sense of patient ownership, which for me is still the heart and soul of primary care. And this, I think, tension is something that I have been struggling a lot with. Now, training programs are used to that tension. Our year is built on a series of varied rotations, and so duplicative and sharing of work and strong transitions and handoffs is what is our bread and butter. But I think that in particularly the primary care setting, this leads to a different set of issues. We, as many programs around the country have done, have transitioned over to a 6+2 rotational ambulatory schedule, which means that our residents belong to teams of 4, and they come for 2-week stretches on a predictable 8-week cycle, and they hand off to each other in a way that allows for our patients to know who your primary care doctor is, who their practice partners are, and when they're all going to be in their offices throughout the year. While this certainly has improved communications and continuity, it also, if you think about it, means that for the patient, their primary care doctor is only around 25% of the time. And for the resident, it means that when you're in practice, you're actually caring for someone else's patient 75% of your time. And what does that mean to the primary care relationship? What does it mean for me to be a primary care doctor? What does it mean for me to be a member of a pod? I think is a real challenge. We all know how to provide acute care coverage for our colleagues. If my colleague's patient calls with back pain or with a spike in their sugar, I know how to handle that. But how do I carry the thread of chronic care with patients that don't belong primarily to me, but that belong to my practice or my pod, is something that I don't think that we've thoughtfully tackled yet. So I am going to leave you with, unfortunately, this unanswered. I think certainly a large component of it is going to be in our communications, not only the skill set, but of course the infrastructure in which we do talk about patients. But I'm hoping that you will all provide me with some of those answers as much as I have provided you with a little bit of thought. Thank you.
Good morning. My name is Tom Campbell. I'm the chair of the Department of Family Medicine at the University of Rochester. I'm also involved in a national group that's looking at the future of family medicine. It's a project of the 7 organizations, professional organizations in family medicine. It is, right? We're switching mics here. I don't like this one, Neil. The Future of Family Medicine is a project of the 7 national organizations of family medicine. Don't ask me why there are 7 organizations in family medicine. It does say something about our discipline, but that's a different talk. So what I'd like to do, I've had the pleasure of being able to think about and learn a lot about the future of medicine and the future of primary care and some of the implications for graduate medical education, and I'd like to share a couple of those thoughts. Futurists tell us that the future is here. We just have to recognize where it is, and that's where we're headed. There are really 2 types of megatrends in healthcare that are worth paying attention to. One are gradual or incremental changes, such as the aging population or the geriatric tsunami that we're all aware of, the obesity and the diabetes epidemic that we're beginning to become involved with, and the overall increase in chronic illness. In addition, there's the increase in insured patients as a result of the Accountable Care Act, and all of those are leading to more need for primary care, and of course going to result in even more of a shortage in primary care. So we kind of can predict that and know where it's headed. The others are what could be called disruptive trends, those that represent paradigm shifts that really change the rules of the game, something profoundly different that will really affect primary care. And I think there are at least two of them. One that we're most familiar about is payment reform. And it is really the change from a volume-based payment to value-based. And I think it is impossible to underestimate the impact of this. It is going to change our lives enormously. And some people, and I'm impressed that Neil is 30% of his life is in value-based payments, maybe more. And it really allows us to do many of the things that we're talking about today. For primary care, the faster we get out of fee-for-service, the better, because it'll allow us, we can't do patient-centered medical home, as I'm sure you're all have learned. You cannot do patient-centered medical home in a fee-for-service. You can qualify for an NCQA level 3, but as Neil said, that's really not patient-centered medical home. That's sort of the baby steps towards really doing it. You need to be in a different kind of payment system that pays for value to make that happen. So this is going to make absolutely profound changes, not only in the way that we provide for care, but also in the way that we need to train. Everything in primary care now that's considered, or everything in healthcare now that's considered a revenue center will quickly become a cost center. Primary care, which is now valued for our downstream revenues, we all know about them, will very soon be about our downstream savings. Now, the more enlightened healthcare systems understand that, and those of you who are in enlightened healthcare systems, you're the ones that all of a sudden have become extremely popular. In my institution, in the last 12 months, we've gone from being largely ignored to being the most valuable player. And they talk about primary care constantly, and our residents are like gold, because our residents are the primary care docs that are going to keep their costs down, and they're going to make their accountable care network succeed. So just to think of one small consequence, just imagine the day that when we see patients, all we have to document is what is clinically relevant and nothing else, that we're not billing for everything that we have to do. So that's one disruptive trend that's going on that really will affect us in major ways. The second is technology, and I think this is a lot more difficult to predict. Although in Denmark, and this is how the future is here, we just haven't recognized it, 60% of all primary care visits are asynchronous and virtual, that is by email. So we can guarantee that we'll see a dramatic rise in virtual visits, in in-home monitoring of chronic illness, on electronic online coaching for chronic illness, and a whole range of opportunities. This little tiny computer, it's not just a smartphone, is really going to change our lives. As I'm sure you know, there's an adapter for this that allows you to do an EKG, and there's an adapter that allows you to do a O2 sat, and I hear there's an adapter coming out soon that allows you to do brain surgery. It really is changing things in a major way, and most of our patients, even our low-income patients, have these. So the opportunities are really enormous. There is a plan or a hospital system, I think it's in Virginia, that has created the home hospital, where they don't hospitalize people, but they bring the hospital to the home. A huge opportunity for primary care there. Ian Morrison, who's a futurist and presented at AAMC, was asked about the physician shortage. He said an interesting thing. He said, "I don't hear a lot of people concerned about a bank teller shortage." I was a little shocked by that. I thought, well, wait a minute. Come on now. A physician cannot be replaced by an ATM or by a computer, right? Then I saw the movie Her. How many of you seen Her? Oh, only a few. Oh, you have to go see it. So in it, a young man, played by Joaquin Phoenix, falls in love with his operating system, Samantha. It is very convincing, as he's smiling, who saw it. It's very convincing and very disturbing. Go see it, and think, could Samantha be the primary care physician of the future? Brilliant and incredibly empathic, and you would like to have as your primary care physician, believe me. So what's the implication for primary care residencies? What do we need to do to prepare our residents for this? I just want to touch on a couple of things. First, I agree with Neil. We're still in kindergarten or first grade with patient-centered medical homes and creating highly functioning primary care. And it is hard enough, as the work of Tom Bodenheimer and others who've gone around and looked at highly functioning primary care, it is hard enough when you're in private practice or non-residency to create these practices. In residency practices, because everybody is very part-time, it is extraordinarily difficult. And I think we need to look more at what are the specific challenges that we face in residency practices to achieve a highly functioning patient-centered medical home. And I agree, being a level 3 is only just the very first step towards doing that. So how many of us are actually doing team-based care in which each member of the team is really working at the top of their license? How many of our physicians are able to stop doing secretarial work? So much of the work that we do it could be done by a secretary, but we're stuck with it. And some of it, of course, is the systems now, not least of which is meaningful use, which requires a physician to do it all. That's extremely physician-centric rather than team-centric. So how many of us are really providing population-based care in which each faculty member and resident knows who their population is, their panel of patients, and gets a quality report card on them on a regular basis? Have we really integrated behavioral health into our patient-centered medical homes and addiction services? I think we've made some progress with behavioral health, but boy, are we struggling, at least in our site, with doing addiction services. And have we moved beyond co-location into really truly integrated and collaborative care? And how are we addressing cost effectiveness and how we really achieve what's driving all of this? You know, we talk about the triple aim, but what's driving all these changes is the cost issue, is the fact that we are bankrupting society, or as a colleague wrote about, cannibalizing the rest of society by the cost of healthcare. So we don't have the cost, we don't have the money to pay for bridges and schools and multiple other things because healthcare is so expensive. So there really is a moral imperative to lower healthcare costs. So are we teaching about it? A few programs, how many programs have gone beyond, say, choosing wisely, which is a great start, but really teaching our residents about the true cost of care, including the cost of all the tests we do? How many of us know how much it costs for the MRI we ordered, for the lab tests that we ordered? And of course, we need to get the ACGME and our RRC to think about the future too. In family medicine, we have the problem that we're counting visits, but it only is face-to-face visits. As we move to virtual visits, we need to get the ACGME to catch along. Finally, I think our residents need to understand and learn about new models of care and new models of payment that are emerging and have huge implications. These are not just ACOs, shared savings, but I think one of the most exciting is direct primary care, in which primary care directly contracts for primary care services only. And this is much more common in the West Coast. There's an organization called Q Alliance that is now contracting with both employers and with Medicaid for primary care services alone. Their first visit with a patient is 2 hours. They have minimum of half-hour visits, and the graduates of the residency programs are flocking there because they love it. They get paid better, and because the model exists. So I'll stop on that and turn it over to my colleague.
Good morning. I'm John Swartz. I'm a regional medical director for Montefiore Medical Group in the Bronx. And I've been providing primary care to underserved patients and in a variety of leadership roles for more years than I'd care to publicly admit in the Bronx. Montefiore is about a $3.5 billion organization and has 4 acute care hospitals, recently turned to 6 acute care hospitals. But when I interview candidates to join the medical group, there are 2 interesting things about Montefiore that I share with them, at least interesting to me. One is a very large primary care network. That's us. We have 22 offices. We do about 825,000 visits a year. I'm responsible for half of those offices, the ones in which residency training takes place, and sites that are more primarily Medicaid focused, 70% Medicaid. And we have another regional medical director for the other half that look a little bit more like hospital-owned private practices. But the other interesting thing that Montefiore has done is to spend the last 15, 16 years getting good at managing insurance risk. And I'll talk about that a little bit more in a minute when we talk about sort of payment reform. So for me, so I like to offer kind of a very ground-up, kind of practical answer to the questions that Foster and Marietta gave us, looking at kind of the changes that I'm seeing going on in our institution now. I think that the biggest sort of change in primary care for the future is the concept of really taking care of patients between visits, not just at visits, at really doing proactive outreach to bring patients in who should have been in for visits who haven't been here, and taking a very proactive approach to transitions. And I have to say those 3 things have really not been characteristics of my practice the majority of my career. And it really is, I think, a very different and positive mode to practice in that way now. I think the other real fundamental change is working within a team that is trying to provide comprehensive care and improve patient self-management. And, you know, we call these physician-directed teams, but in reality, for your team to function well, the physicians have to relinquish a little power and a little bit of status to really allow the team to function well. And I think what we've learned over the past couple of years of trying to roll this out across our primary care network is that putting a bunch of people together and calling them a team doesn't necessarily lead to the types of behaviors that really allow that team to function well together. Like many of you, due to the timing of the hospital medical home grant and sort of renewing our own recognition, we've been very highly focused on achieving recognition for the past year. And we're now moving into really working towards our real transformation. And so I think we have built a substantial coaching infrastructure within the medical group. We have 6 coaches who go out and work with the teams. And again, they've been more focused on developing new workflows to allow us to get the documentation for recognition, but now we're moving into, I think, more interesting stuff. But even within that, it doesn't mean that our teams are kind of have uniform processes, training, and are high functioning. So I think we are one of the HMH-funded projects that we're working on in our family medicine residency program actually is, in addition to developing curriculum for residents and for faculty around patient-centered medical home, is to roll out a team development curriculum across the 2 residency practices for all staff members that was developed in Colorado. And I think we're looking at this as an experiment to see whether this will really help us kind of develop more highly functioning teams. So to go to payment reform, I think in our medical group, we're very fortunate that Montefiore's made the investment that it's made in managing risk. It's really prepared us well for health reform. This year, we'll be at about 50% of our entire institution's book of business, either in global risk or shared risk. The global risk component of that, I think, is really important, that you essentially have a premium revenue stream coming in before you've provided the care. That's really allowed us to develop high-quality care management programs and has also helped us invest in some of the staffing that we feel we needed to make the patient-centered medical home real. Of course, if you're at that end of the spectrum and getting premium, it's very complicated. You also have to be able to pay claims, do utilization management, all of that. I'm not sure that that's a model that's going to be generally applicable, but I do think that some combination of a focus on quality and shared savings is really the only way to get teams focused on the things that actually matter. So in terms of residency training, I think Montefiore has an interesting history. I trained there, Neil trained there as well in family medicine. There's a residency program in social medicine that's 40 plus years old, has components in family medicine, social internal medicine, social pediatrics, and it's focused on attracting and training residents who want to provide primary care in underserved areas, and we have a good record of actually producing those people rather than have them go into subspecialties. Also a pretty good record of producing people that become leaders in the healthcare field. But in our categorical programs, I think the big shift right now is moving to taking responsibility and accountability for a panel of patients that's identified as yours, as opposed to, I'm in clinic this afternoon, my entire thought process around that is going to be contained within those 4 hours, and then I'm rushing back to take care of the patients in the hospital that I'm really worried about. So this is a big, big culture shift for us, and one I think we're actively working on. The other piece of it, I think, is to really enable patient-centered medical home in a residency practice, it has to enter into the precepting encounter. And I've talked to a lot of our particularly internal medicine faculty about this. It's not easy sort of beginning with your interns while you're going through PCMH recognition, because they're learning the EMR. You do need to teach them medicine and patient management. That's a big, huge job in and of itself. We want them to provide the patient with a good patient experience, so we're trying to teach those skills. By the way, don't forget to check the 40 boxes that we need for MU and QAR and HEDIS and PCMH recognition. And then we need to teach them about who are the other team members that you're working with, how do you use them, when is it time to call them in, how do you work together with them. And we've had a very interesting experience in that one of our hospital home funded projects has been to provide what we call PCMH rotation for categorical internal medicine graduates in some of our non-residency sites. They go there for a month, they see patients with a busy internist, they spend time with our care management nurses, they spend time with a pharmacist, with a social worker, with the office manager. We have nurse CDEs, they spend some time with them. And they've come back. It's been fascinating talking to them at the end of the rotation. They've come back, first of all, saying, we need to improve our evidence-based practice in the medical group, but also sort of reflecting that, wow, I wish I had done this 2 years ago. If I knew that this was what it was like, I might have stayed in primary care rather than becoming a hospitalist. And secondly, it was really incredible working with that nurse, the diabetes educator and the PCMH nurses, and it's like, well, did you know that you have those in your practice? Well, no, who are they? So I think putting that whole component into this very compressed time that they spend in clinic is very difficult. Also, I think to make these teams functional, you need time to do it. So they need to be able to attend team meetings. They need to be engaged in some kind of panel management activity and work with some of their other team members. So I think where we're moving, at least in internal medicine at Montefiore, is we are moving to a block schedule in the thought that having those blocks of dedicated time in the practice will allow us to expose the residents much more intensely to those type of activities. Within family medicine, we are, the residency program has also designated blocks of panel management time in which the residency faculty actually work with the residents to deal with some of their patients that may need more intense help or that need outreach, that type of thing. So I think for me, we truly are just beginning with a huge cultural transformation, but agree with the other panelists. I think we're in a really exciting time in primary care and looking forward to what's coming. Thank you.
Please join me in thanking them. They will be here. If you have questions, you can hit them up over the next hour. I'm thinking you might want to know about lunch and the rest of the day, so Erin's going to go through that.
Promise not to take too much time here. Just for a few moments about logistics, there are 2 stations for our buffet lunch, one right here, please go on both sides, and one right out in the hallway outside. Once you get your plate, please eat rather quickly here in the ballroom so that you can have time to visit the amazing poster session and the portal demo, which is on the 3rd floor. We're making sure you get your exercise today. We have 1 hour for lunch. Before I dismiss you for lunch, I just wanted to recognize Anu Ashok and Carla Nelson, and I'm going to ask them to stand. They coordinated the poster session, which you'll be able to visit very shortly. Rather than resuming the breakouts at 1:30, we're going to push that back 10 minutes so you have a full hour to network, visit the portal demo, and see the posters. I just want to take 1 second to have you all look, if you haven't yet so far, on your name badges. There should be a little color-coded dot. That should correspond with the session you registered for, which is in your agenda. If you are going to Care Transitions, you will be in here. If you are going to the Crystal Room or Crystal A or B, which is green or blue dot, you will be right out here. And if you have an orange dot, you will be on the 3rd floor, the same room as the portal demo. So please refer to that. After the sessions, we will have a brief break, followed by a reporting back session in here as well. But please take your stuff with you once you leave after lunch, because this will be at one of the breakout sessions. Thank you very much. Enjoy your lunch.